Ma'am, we can start.
Yeah,
Ma'am, I'll
Ruchika.
start. Yes, ma'am.
Yeah, Ruchika.
Okay. A very good morning to one and all. I'm Dr. Ruchika Ghosh, third year postgraduate student. And here we are back again in the same platform of the Masterclass series. Before we commence today's program, I would like to invoke the blessings of the Almighty to make it a grand success. The Department of Conservative Dentistry and Endodontics, Bangalore Institute of Dental Sciences, in association with AS Karnataka, welcomes you all to the second session of the Masterclass series. It was heartening to know that we had a very good response to the first program. This is going to be an ongoing process, and we have more webinars lined up over the next few weeks. So let's begin the program. I hereby request our respected mentor, HOD Ma'am Dr. Ramya Raghu, to address and welcome the speakers of the day. A humble request to all the participants to mute their audio and switch off the video during the session. Also, we have an interactive question and answer session after each speaker deliberates their presentation. So kindly forward us your questions in the chat box for the speakers to solve your queries. Thank you. Have a nice day. Over to you, ma'am.
Thank you, Ruchika. Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay. Good morning. Greetings to all the faculty members and dear postgraduates. I welcome you all to the second program of this masterclass series of webinars on behalf of our chairman, Shri Katuri Subbarao, our directors, Dr. Swaira and Dr. Siddhi Krishna, our principal, Dr. Vinaya S. Pai, and the staff, Department of Conservative Dentistry and Endodontics at Bangalore Institute of Dental Sciences. Thank you all for your active support and participation. The first program that we held last Tuesday was a resounding success. This has encouraged us to bring to you an interesting program on aesthetic dentistry for today's session. The theme today is biodontics, the art of creating biomimetic, lifelike, durable restorations with modern day composites. We are extremely fortunate to have with us today a world-renowned international speaker, Dr. Abdel Rahman Ali. He is based in Cairo, Egypt. Now, when we say Egypt, what we remember is that it is the land of one of the greatest ancient civilizations that came up along the River Nile. It is the abode of the pharaohs, as well as it has one of the seven wonders of the world, the pyramids of Giza. We thank Dr. Abdel for graciously accepting our invitation at such a short notice. Thank you once again, sir, for being here today. He is going to
It's my
enlighten us
pleasure.
about BioClear mattresses, one of the most successful means to provide anatomically pleasing contours for our composite restorations. He is a much sought after international speaker from Africa, and he is a passionate microendodontist and aesthetic dentist. He is a key opinion leader for BioClear systems, and above all, from what I have interacted in this short span of time with him, he is an exceptionally humble and down to earth human being. A little bit about his academic accomplishments. Dr. Abdul completed his BDS from Mansoura University in the year 2007. He went on to acquire his diploma degree in endodontics from Suez Canal University in 2010, and he is a fellow of the Egyptian Fellow of Family Dentistry in 2016. He is also a member of Tomorrow Tooth Academy, Italy, and a DSD certified dentist from Miami, USA. He specializes in microdentistry and is the founder of Dr. Abdel Rahman Tawfiq Learning Center in Cairo. He's passionate about aesthetic dentistry and has actively participated in several national and international courses in aesthetic dentistry. Since 2012, he has conducted several aesthetic dentistry hands-on courses in the USA, South America, Europe, and Africa. He is a BioClear certified speaker. So over to you, Dr. Abdul, for your presentation today.
I should start now.
Yes,
Let me
yes, sir. Yes, sir.
share the screen. So now everything is okay?
Yes,
The
sir. It's
full
all
share,
clear.
right? Okay. Good morning, everyone, and it's my pleasure to be here with you in this webinar series. And I always like to share, clinical experience. I'm not gonna say it's more than a clinical experience that we can learn from each other. And uh, um, some people think that dentistry is difficult, but it is not. It is very easy to be done. Just you need the passion, and also you need the proper tool to do that. And you need the guide, the recipe that someone tell you how to cook the meal to be able to do it properly. So I am a dentist that used to be an endodontist. So my first specialty was endo. I want to request to anyone is his microphone is on, just turn it off because I'm hearing a lot of noises. If it's possible, would be okay. So I started to do aesthetic dentistry just in 2013 or maybe 14. So my journey with composite and crowns, it's only 7 years. So it's easy to be done. It is not a long-term journey. And the one who pushed me to change my dentistry life was Pasquale Veniti and Marco Mailini. These two guys, they were my friends and my mentors, and they started Tomorrow Tooth group in Facebook. We know all that Facebook helped all of us to change our dental routine, how we learn, how we educate people in dentistry by sharing our cases, our failures. So it was easy to learn a lot of stuff that wasn't before, 10 years ago, that you have to travel and to pay a lot of money just to get some tracks. Now it's available online. And Pasquale, he was the one, and Marco Mailini, that started to post cases in the Facebook with the BioClear matrices in posterior and anterior composite. And the one who invented it was David Clark, the guys over there that he's our mentors. 2016, after 2 years of posting cases in the Tomatoes group, uh, they affiliated me as a board member. I was so pleased that to be a board member in this amazing group. And me, from all of the group members, I liked the BioClear too much, and I started to not to post, only to follow David. I went to his learning center in Seattle, did all the courses that they're doing, the basic, the advanced one, and I became so passionate about the concepts. And I went to David uh, Learning Center 2020 for the seventh time before the Corona crisis. And we were able to announce that we will have a BioClear certified learning center in Egypt. So we have one in Sweden by Johan. This guy is amazing guy. And we have one in England by Claire. And we have one in US by David for sure, and also Charlie. And all these guys are in US. And for me, we will have our learning center in Egypt 2021 this year. And David will come to Egypt in August, 12, 13, 14 of August to lecture also. I'm inviting you to come to the conference because I know Egypt is easy, more than US, but the distance, the expenses, so you can come and listen to him. And also we'll do 3-day courses of the BioClear courses for the anterior and posteriors in the learning center. It's a microscopic learning center, so it depends on microscopes, all the fancy stuff that you need to do dentistry. So this me when I was doing the courses. This first time I met David in Italy here, and this is the last time I did all the courses to finish my modules. Me and David and Ken. So how we analyze our work by photos, follow up, patient acceptance. So the first thing is patient acceptance. That's the best thing in dentistry, that our expectation is more high than our patient expectation. This does not mean that you have just to do what the patient accept, because sometimes the patient accept a very unpleasant work. So this is a monolithic composite restoration done by me to a friend of mine who is a dentist, who is a close friend of me. He's one of my best friends. And me and him, as both of us are dentists, we cannot find any flaws that can tell us that we have to do here polychromatic dentistry, we have to do enamel and dentin. So there is nothing we can do better than that. If you can do that with polychromatic, it's okay for me, and also it's okay for any dentist. And if you can do that with monochromatic, easily, so I would choose monochromatic, because on monochromatic I will be away from the layering technique, from different colors, thickness, voids of adaptation between each colors, which is you can do if you mastering the technique. And this is a 2 years follow-up for the same case. The one this here was just post-operative, and this was 2 years follow-up. So sometimes you should see what the concept is capable of, so you can convince that it is a very good concept, that you have to learn how to use it, because sometimes this is the only solution. He's my friend before and after, Omar. He's getting married next month, and his friends. I did hit that he's 2 years ago. He just get engaged, and his fiancée, she told me she's very happy because he didn't want to close the diastema. He was okay. It's almost 30 years, but I wanted a case, a patient in some conferences, and I told him I couldn't find any patient, so you have to come to close your diastema, and he was so helpful for that. So sometimes, for Omar case, it's you know, balance. It's choice. You can do polychromatic, you can do monochromatic. It's okay. You can get the same results with the two concepts. For this case, it was done by Charlie. A stable periodontium, stable reduced periodontium. We all know that the classification, the new classification for the periodontal disease, it's called stable reduced periodontium. No mobility, nothing, but the aesthetic appearance for the patient is not accepted. And if we think about implant and bone graft, if you cannot go, you cannot go high easily in the soft tissue graft. Beside the morbidity of these procedures, the cost that the patient can afford, and the time that you have to take until you reach the result that you're seeking for. And the only thing that the patient needs to close this gap. So the bi-clear matrix, because it is anatomical contour, the Mylar strip give you multiple solutions that you can use in this kind of patients. Charlie was able to make this patient happy again in one visit, just in one visit, and with a 2 years follow-up, these 2 years follow-up on the right, 2 years follow-up, still she's smiling. You can see the difference in her eyes, how she's happy with the new smile, how this smile changed her life to the best. So knowing the technique, it's a must. Using the technique in all the cases, it's impossible because sometimes you have to do polychromatic dentistry. You have to use enamel and dentin, you have to use stains. Sometimes you have to do ceramics. If I have a patient in my office saying that he needs, like this patient, he needs a copy paste, a replica for the neighbor tooth, in the he's a picky patient. Me, honestly, in this kind of patient, I propose to do two ceramics veneers because no matter I will do, she will not be happy about the result. She will always looking for the flaws. We all know that single center is not easy. However, if she's a normal patient and just need some details, you have to use polychromatic dentistry. And if you are lucky, you can have the fracture piece and just reattach it again, everything will be okay. So some patients need to have the same details, the same incisal halo, the same opalescence, the same dentine thickness. You have to know all of this. Some dentists, I don't know in India, but I have been in India. I did a lot of courses over there, and I know the prices for the composites. No matter the fancy tools you have in the office, no matter how skilled you are, and how many courses you did and all the certification that you can have, you cannot charge too much in composite. So if the patient are picky, I will go for ceramics, not composites. Another case, just for example, that if you want to duplicate the next tooth to you, like here, I need to duplicate all these cracks, all these details. So this is an old restoration, just we remove it and we have the same incisal halo, the same incisal halo, the same opalescence, everything is the same. So bi-clear, in some cases, this is the only solution. We will go through how to customize the matrices. This will be my presentation today. Polychromatic dentistry, it's a solution that you have to learn. It's like, knowing how to do crowns, how to do class 2 restoration. So it's something that we have to teach our students in dental school. It's the same like any other solution in operative dentistry. Before to go to how to customize the matrix, because customize the matrix, it's a tool to get the final results that we're looking for. We have to know what we are looking for, because I did worldwide, almost 25 courses conducted, 25 courses in composite, and in Egypt, almost 125 courses. Less or more, 2 or 4 courses for like 3,000 dentists all over the world in the last 5 years. And I have seen a lot of dentists, maybe more than the half of the people that I did the course for don't know what they should do because they don't know the final shape, the final results of the tooth that they they doing. They don't know where the lining. They don't know what is the lining. They don't know the planes. So we have to know what we want to accomplish by doing aesthetic restoration. Is the same for the lab. Like if anyone, if you, I did some courses for the lab, 30 classes to learn how to do stains, how to do ceramics, and since I'm a composite educator, so it was a little bit easy for me in the waxing up and how to do the waxing up, in the ceramics finishing, how to do this. So first of all, we have to respect the patient. Mm, Let me say, patient beauty. She's beautiful. She's beautiful, beautiful artist, and she has a rotated upper lateral, and it's not affecting her beauty. She's very beautiful. So the patient is the boss. Just if he wants to have a white teeth, he should have a white teeth. Just we tell the patient this, it is not the best, in my opinion, just in showing him cases with different colors so he can know that maybe his opinion is wrong. But we have to part or that we have to adjust to be aware of so we can get the best result. The first one is the soft tissue level, the zenith level. So if the patient come to you like this patient we will I will show you uh, his case. It will be one of the two cases that I am going to show you today. So the soft tissue level is not right. And when this patient come to your office and asking for filling, diastema closure, class 2, class 4, class 3, and you just do the filling. The first thing that he will tell you after you finish all the work, why one tooth is shorter than the other tooth. And he's right, because you didn't tell him that he can do the two teeth equal in length. And when he came to your office, he was expecting to get the perfection. So you have to adjust the soft tissue level before doing that. Also in indirect restoration, believe or not, this patient came to my office to close the diastema. She was okay with the crown for 18 years. Her sister, she's a dentist. She did a crown for her, and she's okay with the color. And I convinced her that we have to change the crown, and the black shadow from the PFM is not okay, and also the size of the crown is not the best. And we did some gingivectomy, and after we discussed the case, I told her we cannot do the diastema closure, because if we did the diastema closure, the teeth will be more wider. You have to do aesthetic functional crown lengthening, and she wasn't okay about that. See, so we chose the middle solution to just change the crown, do some soft tissue crown lensing for the central temporization. Here's the final. So now it's much better than before. So the aesthetic, pink aesthetic is very important. Let's go for the white aesthetics. I'm not going to the color because the time will be not enough to go for that. I'm doing monochromatic dentistry with shades opaque. I just want to know how many times I have, if you can tell me, because I don't have timer here.
You have another half an hour more.
That's okay. That's very good. So for the white aesthetics that our teeth, we have shaped mean like height and width and thickness, volume, and we have surface characterization, like, you know, how many operations you need to do in the surface. And we have optical properties. Optical properties, it comes from the color of the composite that you choose, and also it comes from the surface characterization that you have done on the labial surface of your restoration. So the shape means that you have to know the shape. You have to know, you know, when we do posterior composite restoration, very example, very simple example, and do the upper first molar. Usually in my courses and also all the courses that when we do the hands-on, they will do either the lower first molar or they do the upper first molar. And the candidate usually ask for, you know, the videos for the hands-on, which is available online. But after telling him that we do the upper six, if you have an upper second molar, what we will do, or you have a lower five, you have to know the anatomy. You have to know the shape, you have to know the proportion of each tooth, and you have to be variable, like you have to accept customization. Because just let me, because you sometimes you might do a different anatomy from the normal that you usually do. For the anteriors, it's a little bit picky, so you have to know what is very important, what is not important. The one is very important, that the two central have to be identical, like twin, identical brothers. The two laterals, it could be sibling. The canine, no, it's okay. So you will not leave the patient with this over molding, just, you know, width and height, volume accepted. This is about the shape. The surface characterization, it's primary, secondary, tertiary anatomy. The primary anatomy is a line angle. The secondary anatomy, the loops waving on the labial surface. The tertiary anatomy is the pericymata, which is not good, from my opinion, because pericymata is in composite, in ceramics, it's very good. It's not easy to polish, and if you're not able to polish it very well, it will stain easily later on. For the shape, the height and width, and also the planes. So the tooth have cervical, middle, incisal plane, and it has also height, and also it has width. This is the shape. For the surface characterization, you cannot do any surface characterization unless you have done the height and the width and the planes? Probably. Because if you didn't finish the size of the tooth and you do surface characterization and you realize that you have to reduce the volume because you have to change the plane, you will lose all the surface characterization. And you can do the analysis of this by taking photos so you know what you should do. So this is what I mean by surface characterization, the same loops. This composite, this normal. So these the same loop, the same loop, the same loop. Why we have to do the same surface characterization? Because the reflection of the light give you the natural appearance that you're looking for. If you have two same reflection, now you are good. I'm not talking so far about Bikely because Bikely has nothing to do about this. This is about you. You are the one who has to know that how to do this kind of finishing. Because if you're not able to finish, you will get ugly tooth. Especially with the Biclear, you inject a lot of composite. Then you are the one who have like waxing up. You know, if we comparing between someone doing hand waxing and someone doing CAD cam waxing, the software proposed to him some solution. We just adjust a little bit. So optical properties, it depends about the thickness of the composite and the type of the composite that you're using, and not this image. So if you want to say optical properties, the inside the halo, the opalescence, no, this is not what we're looking for. To know how to adjust your matrices, you have to know and you have to imagine what you're looking for. So I know that there is no interaction, so I will be the one who interact with myself. In this case, we call it class 3 and also class 4. And if we imagine how we want to finish this case, so it will be like that. So
قلناش بالبكس
we get a proper, what you saying?
تايلر يا لما
Someone talking? Okay, I'm okay or not?
Yeah,
If
Dr.
someone
Abdul,
was
please continue. I think somebody's got. Request all the audience to switch off their microphones, please. Dr. Abdul, you can continue. Thank you.
okay. So you want to get the proper contact position. This is the first step that you have to ask yourself how to get this. And this is the same thinking if you're doing indirect, like if you do crowns, you probably will go deep. This is super changeable, so probably you will go deep here, so you get the lab space to get the proper inversions profile.
سوبر يا اوكي
If you please, my friend, just mute all the
كي
microphone, or the one who is responsible for the room, just mute all other people because
Sumit,
I keep
yes.
I keep hearing a lot of noises.
Yes,
So
sorry.
we were saying that this is a class 3 and this is a class 4, but we didn't say it's a diastema. I would rather to call it as a diastema because by calling it as a diastema, the first thinking that you will ask yourself or you realize the new immersions profile. So I will call it a space caused by carries. And this is a space with no carries. So just call it a space. It's a space. You have to fill this space. And the second thought, how to fill it and what the final shape you're looking for. Now you will able to adjust your Biclear matrices. So H class 3 is a black triangle. This is a black triangle. And if it was a curious cavity, it will called a class 3. To do anterior composites, layering, Biclear, whatever you want to choose, the way you do your filling, you have to do rubber dam isolation. So if you don't use rubber dam, you're not in the game. You have to use rubber dam. I believe that most of the dentists in India are using rubber dam. So how to do this? How to get the proper adaptation of our composite to get that, not this. How to get this X-ray? Proper adaptation in the phalangeal margin. We have to use the proper matrices. We have to use proper material, because you can choose the proper matrix, but you didn't fill the proper material. And you choose the proper material, but you didn't fill it properly, and you can fill it properly. A lot of dentists, they are able to customize or choose the proper matrices, choose the material and apply the material properly, but when they do finishing, they roll it up. Also for the polychromatic, by the way, some people do enamel and dentin very good, and when they do the finishing, they messed up with all the filling that they have done. So the finishing is very important. I'm using Biclear and Tourvein. Today I'm going to discuss the Biclear. Biclear, I got this slide from Disha. This is a very good slide. It's a big family, and it's like any company. They do matrices. They realize that this is no good matrix. We have to do better one. They do different thickness. They do give us a lot of solution. Some people like me, like all the family, use all the family. Some people cannot afford do that. So we are as educator, we give him or tell them the differences so they can choose 2 or 3 matrices just to do all the restriction. So Biclear started as a thin matrices, and we call it the original matrices. And after that, they realized that the thin matrices, it is not the best thing to use because it is very fragile. So it's easy to bend. So they started to manufacturing thicker matrices, which is called HD matrices. And all the new matrices that they came up later on, they don't do it in a thin matrix, they do it only in a thicker matrix. That's why you have a little bit of matrices in the thinner group and a lot of matrices in the thicker group, because the new matrices was done only with a thicker matrix. They still doing the thinner matrices. Some people like it, like me, but it's not easy to be used. So let's go through all the matrices that they have. They have anterior matrices, and you have to be focused about what I'm saying because it's a little bit confusing. And they have diastema occlusion matrices. And I want you to forget about this name, because when you buy the box, it called anterior matrix. in another box, it's called DC, diastema occlusion matrices, and just forget about that. We call it pink matrices, green matrices. And each group of these two matrices, the pink and the green, we divided the matrices according to the surface that you're trying to fill. Mesial of the upper anterior, distal of the upper anteriors, lower anteriors. If you're doing the mesial, so it's 1. If you're doing the distal, it's 2. If you're doing the lower, it's 3. If you're using the pink matrices, so it's 101. If you're using the green matrix, it's 201. So the green start with 2. Still, it is 1 because it's a mesial. Distal is 2. If you're using the pink, 1 or 2. If you're using the green, 2 or 2. If you're using the pink, 1 or 3. If you're using the green, 2 or 3. So the first number indicating for the green or pink, the last number is indicating which surface you're filling. What is the difference between the original matrix and the HD matrix? Is the thickness. What is the difference between the pink matrices and the green matrix? Each of them has a mesial upper anterior, distal upper anterior, and lower anteriors. The main difference is the emergence profile. How curve, how steep the emergence profile you're looking for. This is the matrix that you have to use. So if we picking, let's say the distal of the upper anteriors, we have 102 and 202. The 102, this is the emergence profile. Like how steep the matrix, how curvy, how convex the matrix until it will be straight again. And this is the 202. So if you have a wider space caused by caries or by just malposition of the teeth, you will go for the matrix with a more emergence profile. If you have a narrow space, you will go for the matrix with less emergence profile. Just it. Will you do mistakes when you choose the matrices? Right, you might think that this case is good for pink and you pick the pink from the box and you see that the emergence profile is not the best and you throw it away, you will choose the green. Yeah, it's a learning curve, you have to pay for it. So how to adjust our matrices? Here, it's space between the two centrals. It might be caused by caries, it might be caused by non-caries. And we have to get the proper emergence profile like here. Pink or green, for sure green. You have to use a green. And how curvy it is? What's the length of the emergence profile? It's 1 millimeter for the green. And how is it? How much is it for the pink? It's 0.5 millimeters. So if you have a space between the two central is 2 millimeter, so you need 1 here and you need 1 here. If you have a diastema for 1 millimeters, you need 0.5 here, 0.5 here. So you can use the pink group to close the diastema. If you have a 1.5 diastema, so the green will be too big and the pink will be too small. So what should you do? you have to adjust the matrices. How? You have to push this matrix apically here. And what is preventing you to push the matrices? The cervical part, this part. So you do a V notch in the matrices here. So you can push the matrix apically. It's like doing a deep subgingival finish line so the lab can go for deeper emergence profile. Okay? Here is the DC group 102, 202, sorry, and also 203. We're not going for the 204. And this is the A group 101, 102, and 103. They do it in a thinner matrix, which is called the original. They do it in HD matrix. These are the only matrices that we can have in the market with different thickness from Biclip. They have also another matrices. Before to do that, let's go for this quiz. This case was done by David Clark. And he has a crown here. He will change it. Black triangle, diastema occlusion, black triangle. Which matrix we use here? Green. Which matrix we use here? Pink. And to be honest, this matrix that we will use here, it will be customized green, because the green, it will be too bulky. The pink will not be good. And for the distal, we'll use pink. But remember, before you applying the filling materials, you have to take the photo and you have to see this. What is this? This is the emergence profile. It is not a mystery. It is not something that you see after you finishing the composite. It's not like the old, Milo strip. You apply layer by layer by layer by layer, and you will see how the results will be, because from the beginning, how is the emergence profile will look like at the end. So he did finishing first tooth, remove the crown, and this is the final. Why these two restoration looks the same? Because the reflection, the same reflection on, for sure, the same color, or at least closed color to each other, before and after. Because of the customization thing, they came up with the new matrices. They called it black triangle. It's not only for the black triangle, it's also anatomical contour matrices. We had the pink and we had the green. So they did two colors, one between the pink and green, which is the yellow, and one bigger than the green, which is the blue. And they gave you a gauge, a prop, a colored measurement tool to tell you which size you have to choose. It's very easy, and also it's very expensive. So you can use it, and it will be nice. To sum up, we have the anterior matrices 101, 102, 103. We have the diastema occlusion matrix 201, 202, 203, and we have the color-coded matrix. I would like to call it color-coded matrices, not a black triangle in the market. So how to customize the matrices before we go? How many minutes I have left? Just let me know.
You can continue, doctor. You can continue.
Okay. So this is how, let me do the videos from the beginning, and you can see here the bulky. It's very bulky. So what I did, the same matrices, uh, I did a customization here. Now the emergence profile is much better. I remove the clamp. I'm doing a customization for the same matrix. It's still, it is not the best here. It's not okay. So I will do cutting. Also, the flanges is not the best. So I do trimming. If you are afraid that you do too much customization, you can use any color coded pen to mark the area that you want to trim it, so you will not trim more than you need. You can do that. Also customization. Now it's much better. Same matrices. See, was the same matrix. Let me pause the video. The emergence profile now, you can see it's perfect. The contact position is okay. And also the width of the matrix. So we customized all these. You are the one who has to do that. And how you will do that, you have to know the final shape. If you don't know the final shape, study the anatomy. You have in the school some um, subject called dentation or dental morphology, I think. So you have to flashback all these, shape, the carving, all this kind of stuff. So after finishing the first one, you will do the second matrices because it's mesial and distal matrix you have to choose. These the second matrix, we will do the same steps. You're not able to close the diastema. You have to split the space between the canine and also the lateral. So you will do just like fixation of the matrix of flow. The clamp was placed to push the tissue down. So you can do, you can have a proper measures for this one is okay, this one is okay. Now you will see how I fix my matrix with the flow. So I'm not going for the 2 VM. It's not our. And I can have a little bit more 5 minutes. So let me go for the color so people know how I choose my composite color. So the color of the composite is divided into 3 parts: the hue, which is the color itself, the value, black or white, and the chroma, the intensity of the color. And we all okay, all the companies of the composite, they all go for the hue, and some of them, they give you syringe or capsules, um, if, according to the chroma, and some of them give you according to the value. And the company that it based on chroma, they usually will give you not less than 25 syringe, and the company depend on the value, they will give you not more than 5 syringe, because the changing in value, it's not easy, but changing a chroma is easy. Let me tell you in this way, the chroma based composite, it's like the way that women choose color. So we, us as a men, we know only green, black green, or like dark green and light green, dark blue and light blue. We don't know the name of the color in these two blue. And some of us only know blue. They don't know blue, dark, it's only blue. So for us, it's easy to pick our clothes. For women, they know all the colors. So, which is okay. It's a gift from God for them, but it's confusing when they buying clothes. So it's no, this is not the same colors. It's okay. It's the same way for composites. So I would like you to use a value-based composite. If the company not doing a value-based composite, I will reclassify the chroma-based composite that I have in a value-based composite, like 3M. So I'm choosing 3M. I will just jump to this. I'm choosing 3M composite, not because 3M is the best, because I used to use 3M. You can use Dentsply, the new composite for Dentsply. It's perfect, and I think it's much cheaper than 3M. You can use Colzer composite. You have to use Compules, that's it, and body shade composite, not enamel and dentin. So my experience with the 3M, Dentsply, and ENA from Italy, but most of my cases I'm using 3M. 3M, it's a chroma-based composite. They doing a lot of shades. For the body shades, we talking about all this too much shades. So which one I do? Which one I should use? Let me divide it to you according to the value. If you treating a child very high value, very white, you will go for white body. So this is the first color. If you treating a teenager's bright tooth, but not too bright, you will go for B1. If you treating like to late 20, early 30 or late 30, you will go P2. If you treating early 30, but he's a little bit smoker, you will go for A2. I don't like the A too much, but A2. If you treating a very heavy smoker or dark teeth, you will go for A3. Justin, 5 colors. You don't need all these. I classified the composite according to the age and the value, like essential enamel and dental. I like it the way they do that. This chart, young, like junior, young, adult, senior. You cannot have all these color, and I know all of you clinician and professors in the webinar that they have a lot of composite in the office that they bought and they didn't use. They just keep it in the drawer and until it get expired. They use it as a build-up material sometimes just to not throw it away. So let me jump also about this. How to sorry. Okay, I have to exit first so we can go. How we apply the material. First, we all have seen the tiny space of the cavity we are planning to fill. So the material has to be a little flowy, so it's easy to be adapted in this space. To be flowy, you have to heat the composite. And thanks to the social media, it pushed the companies to accept by evidence that you can heat composite. We have a lot of research supporting heating, a lot of research, but none of them was done by the companies. It was all done by the researchers in the university. No companies until 2019 approved that you can heat their own products. And 3M in 2019 they came up with a research that you can heat our Filthic One Supreme, and it's okay to do that. It's okay for us. We didn't wait for this research, but it's okay to have this, and maybe the other companies will also go through that. How many degrees you need? 85 Celsius is okay. 58, sorry, 58 Celsius is okay. I'm using 3M. I'm using Bicley heater. You can use any heater in the market. Just pick a good one. Why I heat the flowable? Because I need to use a small tip, a very narrow tip. So if you're using a narrow tip, you have to heat the flowable a little bit. How I can apply the composite? Can I do it in a layering way with the BioClear, with the monochromatic composite? You can do that. But let's imagine how I make sure that the composite is adapted here in all these arrows. Very tricky, very tricky. Or should I do this? Just how many of you when he has done this filling, he got, oh my God, how will we finish that? I was the one. I had the same problem. It's not easy, but when you know how to do that, you will know that this is the best way because you know your tooth is inside this mountain of composite. You just need to carve it and you will have the best monolithic restoration. How to do the injection? You do flowable first, you don't cure it and you do the injection. We don't cure. I'm showing you these videos so far because people think that we inject paste from the palatal. We don't do that anymore. We just do from the labial and the incisor. We do the flowable from the labial and the palatal, and we do the paste from the labial and the incisor only because when we used to do the palatal and the labial paste, we end up with a lot of voids. You have to have a lot of composite and don't remove it, because if you remove it, it will be messy because you will do voids, you will interrupt the fluids. Little bit of massaging and just to cure it. And with the finishing, you will get the shape that you're looking for. And when you do this kind of massaging, you have to do it a little gently, not too heavy. So how to do the finishing? How to go from here to there? You have to use discs. I'm using 3M discs. Um, to be honest, this is the best disc in the market. Maybe Care also is okay. Care, from my experience, 3M Care. I don't know. I don't know any other companies. I have no experience with other companies. But I use only coarse disc, extra coarse disc. When I start to do the finishing, removing a lot of excess composite to the disc, the extra coarse disc became like a medium disc, and at the end it became fine. So I use only one disc. So I don't buy the whole setup. So how we do that? Let me show you with the disc. This is not 3M, this is a 2VM disc. I used to try it for a while, but I didn't like it. Now we do the finishing labially. Here's a pair from Comets. It's a low speed pair, low speed diamond pair. You can use it in 11,000 RPM. And the debris, if you want to know which guide you follow the debris. If there is no debris, there is no debris, there is no debris. So this is a depression area. If you want to have a flat surface, you have to have equal debris. Now with the disc, you start to recontour the line angle. And remember that the speed of the disc is very important, not more than 5,000, 3,000 RPM. So you have to use electric motor to be able to control the speeds. I know it's not possible in the college, but you can use the adapter to adjust that. Okay, can we finish with the birds? Yeah, we can do that. Let me show you. I don't do that anymore with the water. Usually I do the finishing dry because I need the debris to guide me. And also I want to have a second chance if there is any voids to correct or to adjust it. How many minutes you?
Another 5 to 10 minutes, sir.
Okay, so we will go for the case now. Okay, let me go through the case so we will not lose time. Okay. So there's a patient, his wife, she's a dentist, and he has crowns here, crowns here, and you can see all this filling. He came to my office, want to fill his front teeth, and this is the photo you have to take so you know this tooth is going forward, this one is going back, and also the soft tissue level is not okay. At that time, I was not, okay to do mm, over molding, like too much filling. So I used to split the cavity, which you can do if you're a little bit afraid of having bulky restoration. And I was not good for finishing for the line angle you can see here. It is not the best you can get. I did some direct mock-up to see the final results. Some gingivectomy here, soft tissue, removed all the filling, did some labia reduction here, so I pushed the tooth that going forward a little bit back. Placing my matrices, I told you that I used to split the space, split the cavities. So I did the proximal distal first, and I did the mesial later on. And my matrix here was not good, so the contact was a little bit high. So I had to redo it again to move the contact a little bit down. And I used to do a lot of perikymata here, perikymata. And this was the final results. It's not the best. Anyway, this was 2017. 1 year later, he came to my friend in his office in Cairo. My office is not based in Cairo. We will open the new office in Cairo in 2 weeks with the learning center. And he sent me this picture with soft boxes, which is okay. Same picture, same day with the ring flash. I can see that the too much anatomy is getting stained. And the key line here is not the best. He came to me 2019, like 2 years after the first filling. So I did the canine and I redid all the labial surface only of the anteriors. So you can see here the line angle is much better, the line angle is much better, the line angle is much better. The labial surface, it's more smooth. In 2021, 2020, sorry, 2020, last summer, or not the last summer, in January 2021, this year, he came to me. This is was the results. We're talking about 4 years of the filling. Why he came? Because he want to fill this restoration. You can see the harmony of the composite, the chameleon effect. You see, this one was after just adjusting the labial surface with A2 color in these after 2 years of rehydrations of call it. This is the beauty of the composite. It get the color from the other teeth. For his lower teeth, there is no solution but BioClear. You can see how deep is the cavity. What kind of emergence profile you're looking for. In this case, I used the color-coded matrices from BioClear, the black triangle matrices. Now I am okay to do the overmolding. I'm just showing you that my learning curve in this case. So I used to do that, now I do that. It's okay to take the stairs to get the perfection that you're looking for. And I did the other tooth, and through the canine only to Flumeyer matrices, and this is the results. And this is a good picture because it shows you the color of the anteriors with the saliva, with the normal color of the anterior that the patient actually look like when he's talking, and when he living his normal life. You cannot tell. And he told me nobody can tell that I have done anything in my front teeth. Very good. The canine, the lateral, the central, it's all filling. And this is crown, 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 this is crown. And this is the filling they have done. And this is us just 1 week later. You can tell. You cannot tell that there is a restoration over there. And we saved a teeth. And to be honest, I'm not just saying that with BioClear, without BioClear. No crowns can be done here because you cannot do the filling, because you have to do the filling before the crowns. So you have to teach students BioClear, and you have to know as a clinician this solution. And you choose it when it has to be chosen, and you just wait solutions. This will be my last thing I can see here for the presentation. If anyone need questions, just let me know. I wanted to focus more about the concept, the philosophy, the matrix selection, just so you showing you one simple case how to do that. And if you have times, you can see the diastema occlusal cases, the black triangle cases in my YouTube channel or my Facebook page. And I'm inviting you all to join David's lecture in Egypt. If you have time, it would be nice to having you all there in Egypt. And I hope you will go through the crisis in India safely. Wish you be safe and in a good health. So thank you for inviting me. And I don't know if there will be any questions open. Just let me know.
Thank you so much, sir.
Thank you.
Okay, sir, can you please stop sharing your video?
I will do that. Just let me. I did
It's not yet gone, sir.
Okay, ma'am, go ahead with the questions.
Yeah. Thank you, sir, for such a wonderful presentation. You have covered so many aspects, like choosing the proper matrix. You explained about the importance of surface characterizations. You explained about the choice of composite material that we have to go with, and also about the technique, the actual technique. You have demonstrated the actual technique of using these matrices. Thank you for this insightful lecture. Now, there are some questions that have been put forth by the audience. So I think I would like to quickly go through some of these. So one question is, do you have a problem after removing the rubber dam, is the emergence profile in any way affected because of the presence of the rubber dam? Have you faced any situation like that? Do you have space under the composite once the rubber dam is removed, and then it becomes a problem for you to once again do the restoration?
No, if you have a space, you should have a black triangle when you're placing the rubber dam, because the rubber dam pushing the tissue down, and you have to have a space for the papilla to go back. And if you have a space after removing the rubber dam, it's okay. If the question about the black triangle after removing the rubber dam, and you think that you has to fill the space, no, this is space for the papilla to go back.
Okay,
If
you
there's
follow
the
the
question.
Tarnow's principle. You follow Tarnow's principle in locating the contact point.
Yes.
Okay, sir. Any other than 3M, do you have any other preference for composite? You said 3M, you have the right chroma and the consistency, everything is good. So any other composite material that you would like to suggest?
Densaply.
Densaply. Okay.
Yeah. The new one for Densaply is very good.
And one more thing, sir, for this injection molding, are there any specific warmers to warm the composite? Do we have to go only with those, or do you have any customized method that you have developed
What? Do what?
for the warming of the composite, for the injection molding process?
You have to heat the composite with any heater.
Yeah.
You don't have to buy
Yes.
BioClear. You cannot
Okay.
warm the composite with the light. No, you have to
Okay.
use a heater.
Any specific heater that you would recommend or suggest?
I'm not familiar with the which is available in the market, but I have seen a lot of Chinese, Korean product, which is okay. It's a coil. It's like in heater.
Okay.
You will
And the
buy a Chinese
temperature?
one, you will get you the result, but it might not last for long as a device. The temperature is 58 Celsius.
Okay. Sir. Okay, sir. Thank you once again, sir. If there are any more queries, we will just mail it to you and you can answer it at leisure.
It would be my pleasure. Thank you, and have a nice day.
Thank you, sir. Thank you, sir. Over to you, Ashish.
Yeah. Thank you, Dr. Abdul. That is wonderful. And thank you so much for coming aboard at such a short notice, taking time from your busy schedule. Our next, to introduce our next speaker, Ruchika,
Yes, sir.
can we have him?
Yes, yes. So that brings us to the end of the first presentation. Moving on, Moving on to the second lecture, I hereby request our senior professor, Dr. Ashish Shetty, sir, from the Department of Conservative Dentistry and Endodontics, to address and welcome the second speaker of the day. Over to you, sir.
Yeah. So hi, very good afternoon. So it gives me pleasure to introduce our next speaker, who I have been known, who I know from the past few years, and it is wonderful to have her here because she has such a inspirational journey for all you postgraduate students, and she's a tremendous clinician, fantastic cases, and I personally follow her work. And I think each and every one of you should see it to believe it. And she has had a very interesting journey. She graduated from Savita Dental College as best outgoing student, and she completed her post-graduation in Maharishi Markandeshwar University and the field of conservative dentistry and endodontics. Since then, she set up a private practice called Dentistry, and she also in Kolkata, and she has her own training academy there. And she is one of the very few accredited biomimetic dentists in the country, and she has completed a mastership and training under the mentorship of David Alman and Dr. Davy Alman in 2020. She has undergone extensive training in microsurgical endodontics and in UPenn, Penn University under Dr. Kim Sunja. And she is one of the certified BioClear mentors in the country. And she's done a training under David Clark. Dr. Disha currently is pursuing her diploma in laser dentistry from Vienna. And I think she has many more affiliations. So one of her keen topics of interest is ergonomics in microdentistry, which she developed training under the legendary late Dr. Massimo Mazza at his office. Now, Dr. Disha is committed to provide treatment of the highest quality. So for all you postgraduate students, if you think of many more milestones, what to do after MDS, I think all the answers is here. Most importantly, she's a very approachable person, very nice human being. I personally interacted with her and always ready to teach, always ready to help. So I think, Disha, thank you for coming on board. We welcome you from the team of BITS, and you can carry on with your presentation.
Hello. Can
Yeah,
you
we can hear you. Go ahead.
Ashish sir, can you hear me?
Yes, loud and clear.
Thank you so much, Ashish sir, for the beautiful welcome. I've known you, it feels like I've known you forever now, and it's always so nice to interact with all of you. Today, I'll be talking about biomimetic dentistry. There's something which is very new, which I have learned very recently. From past 1.5 years, I've been investing my time to study more and more about this. So we as an endodontist, when we walk out from our college and we join the practice, a lot of cases will be directed straight to you. You know, patient comes with pain, you have to do. Patient comes with broken tooth, you have to do. Patient comes with badly broken down tooth, we have to do. To some extent, we also have to do prophy. So what I understood in 1 year of my practice was I need to know a lot of stuff. Just specializing in one thing will not be enough. I need to do aesthetic dentistry, I need to do veneers, I need to do post-in-course. If possible, I also need to do onlays, inlays, besides doing the basic root canal. So my heart has always been more towards the restorative dentistry than towards endodontics. And, you know, I have been working more and more towards giving a better aesthetic job to my patients. I have undergone a lot of training. And before I start, I would like to thank all my mentors who've trained me over the years. So, Ashish sir, can you hear me properly? If there's any problem, just stop me. Okay?
Yeah, we will ping you. You're loud and clear, and it's full screen now. It's fine.
Okay. So this is my clinic. I practice in Calcutta along with my husband, Dr. Ankur Gupta, who's a prosthodontist. Together, we've been running dentistry for last 5 years, and it has been a wonderful journey for us. We have had our ups and downs, but yes, we are focused towards developing more and more. I would like to thank all my mentors over the years, Dr. Siju Jacob, who's trained me for microscope dentistry. I cannot thank him enough. Those 2 days has changed the way I practice. I would say to all the endodontists out here, do not waste your time once you get into your practice. Set up your microscope. It will change the world for you. Dr. Massimo Mazza, Dr. Wendell, who's given me gold foil training, Dr. Dental Technician Mastana Shedman, Dr. Martin Trove, Dr. Kim from Penn University, definitely my whole BioClear team, Dr. David Clark, Dr. Charlie Regaldo, Dr. Mark, Dr. Nishan, Dr. Pascal Venute. It's been an overwhelming journey. I have met so many beautiful clinicians all over the world, and definitely whenever you meet somebody, you learn. You learn a lot. And I would always inspire you all to go ahead Learn from everybody, whatever you can do. Even one point taken from one person is a gift to you. So today I'm going to talk about biomimetic dentistry, 6 lessons approach to biomimetic dentistry, the Alleman's way. Why I call it the Alleman's way is because my mentors, Dr. David Alleman and his son, Dr. Davey Alleman, has actually trained me hours and hours and hours and hours of sessions, maybe more than 100 hours now. So what was all this learning was, we have a set of lectures which we listen to, and then we really need to read. That is, read all the literature which is available. It's not just that, I've been told that we have to do this way and we do it that way. No. After analyzing 20, 25, 30 years of literature, the data, the Dr. Alleman has studied over those many years and derived one of the best ways with which we can manage badly broken down tooth. So that is why he has developed this technique of 6 lessons, which you all need to excel to develop good restorations for your patients. So before anything, rubber dam and magnification. These are the 2 basic requirements for you to enter into your biomimetic dentistry. So the earlier you start into it, the better it would be. To begin with, let's start from this statement. Adhesive dentistry could be expressed as a simple relationship between your bond and the stress. If the bonds can withstand the stress, your restorative technique will be successful. Very simple. If there is a composite in there, composites is basically monomers. Or monomers, when we give in the light or we give in a chemical cure starts, it converts into polymers. When monomers become polymers, they try to shrink. This shrink will create a stress. What will be the stress? Your enamel or your dentine is trying to bond to that polymer, and as well as together your polymer is shrinking. So a kind of stress is developed. Now, either your bond is strong or your stress is strong. If your stress is so strong, it will not bond to your tooth. And if your bond is strong, your stress will get overcome and you will have a successful restoration. So usually when I start my presentation, I always put forward this question. Does composite bond stronger to dentine or enamel? So whenever, unfortunately, we're not having an on-site events, whenever we have this event, I'm sure most of you would agree that composite bonds stronger to enamel. But this was my opinion about 1.5 years back. Now I can say this is not for true. Why? We'll see very quickly. Now, suppose there's a slate on which a half portion is your enamel and a half portion is your dentine. And you take a block of composite, you place it all together on your enamel and your dentine. What will happen? And you light cure it. So what is going to happen? Now, enamel will bond very quickly to your composite. Okay, it does not mean that it's bonding stronger. It's bonding very quickly. Okay, composite is bonding very quickly to your enamel, but it does not bond as quickly as it is bonding to the dentine. Okay, so if I have to explain it very simple words, imagine something like a Fevikwik and imagine something as a Fevicol. Your dentine is a Fevicol and your enamel is a Fevikwik. Now Fevikwik will bond very quickly, it will set immediately. Okay. Now Fevicol will take its own time to set, right? It will take few minutes, say around 5-10 minutes to, become that, to get that kind of strength in that. But do you think that after 24 hours, a Fevicol will be stronger than Fevikwik? Give a little pressure to Fevikwik, chuck, a splash is going to break away, but your Fevicol is going to stay strong. So just understand in those terms, your enamel is something, the bond is very quick. Okay, it's going to be strong. It's not that it's not at all strong, but to say that the dentine is not stronger is not right. To develop a very strong bond to your dentine, you need to give it a little time. Okay, you need to decouple your enamel and your dentine. So I'll be introducing few terms which you might not have heard before, something like hierarchy of bondability, decoupling with time. So these are terms which I will be introducing you today, but these have a lot of meaning to it, and this presentation will help you give a little insight to that and simplify it for you. Okay, so now what happens if I bond it together? This is not developed, the bond in the dentine has not developed as strong, but the enamel bond has developed very quickly. So there was a polymerization stress or a shrinkage which was developing in the composite. So my composite started moving towards my enamel. Why is it moving towards enamel? Because my enamel is more bonded surface. So whenever we have a polymerization stress or a shrinkage that is developing, the composite will move towards the surface which is bonding more faster. Okay, so what happens is it separates out from my dentine. Okay, now how can we avoid that? How can we prevent our dentine separation? What we do not apply the composite on dentine and enamel together. What do? We apply the composite only on the dentine first. Then we wait for some time. That is what we call as decoupling with time. I am decoupling my enamel from my dentine with what? With the time. I'm giving my dentine some time to become a little stronger. Let the bond of my dentine mature. And then is when I'm going to apply my composite to the enamel. Okay, so this is what is the sound basic of biomimetic dentistry. If you've understood this, you've understood biomimetic dentistry. Okay, now let's understand the implications if we don't do this. Post-operative sensitivity. What happens? We've been very quick. We got a cavity, we did the tooth preparation, we filled up all the composites. Now what did? We did not give time for the dentine bond to mature. We quickly placed in a composite, light cured it, finished, polished, send the patient off. But what happened? My composite, because I did not give time for my dentine bond to mature, my composite shrunk away and it moves towards the enamel. So my restoration is staying in the patient's mouth. It's not dislodging because there's a bond to the enamel. But what is going to happen? There's a space that will create in the dentine at the bottom of your tooth prep below your composite. So now what happens if there is a space? You go ahead, the patient is going to bite. Dentine is a living tissue. There will be exudation of dentinal fluid. Patient is going to bite into it. Then he'll release the pressure, and whenever he release the pressure, there's an outward movement of the fluids, and that is going to cause the sensitivity. So why do we get composites? Why do we get post-operative sensitivities when we do composite? Everybody clear with this? That is because we've not been giving time for our dentine bond to mature. We are not letting our dentine to form that strong bonds, and we are applying a composite on the enamel. So the shrinkage is going towards my enamel, and there is a separation of my composite at the base of the cavity. Okay, and then when the patient eats or bites, or whenever there's a constant micro movement, there's a movement of the fluids, and the patient will start feeling sensitivity. Now coming to the next problem. Not everything is nice. We talk about enamel bonds, enamel strong, but sometimes the other problem is your white lines. So what happens and why do you get a white line? So we've understood the problems with polymerization shrinkage, why we are having. Now let's understand why we are having a white line. So we did a good restoration. We have a composite in there. Suppose your bond in the dentine is not very strong, you're going to have a sensitivity issue. Now what happens is, when you've placed in and composite in the enamel, and the shrinkage of the composite is very high, but you have a lot of unsupported enamel on this area, okay, in this area, and we've not done the beveling. We've got those very sharp line angles, external line angles, and unsupported enamel. Whenever this shrinkage is happening in the enamel, in the composite, this unsupported enamel is going to get some kind of microfractures. So your shrinkage stress of the composite, when it's higher in the enamel region and your enamel has a lot of unsupported areas, your white lines will start appearing in those areas. It's not necessary that they're going to straight away break out, but yes, the lot of ditching that we see over the time, and as your abrasion of the composite happens, a lot of ditching is because of this white line and these micro fractures which are formed. So the best way to prevent them would be to give a very small bevel, especially I think Dr. Abdel has introduced you to those color lily burrs, those radial bevel Christmas tree shaped burrs. That would be one of the best to use to remove these microfractures. And that would be the second thing that you would do to prevent the white lines. Okay. So now the third thing which I want to introduce you is, do dental composites always shrink towards the light? We've learned this. I have learned this all 8 years of my college, you know. The polymerization shrinkage is towards the light. The polymerization shrinkage, you give in the light, when you're using a chemical cured, it will be centripetal in nature, centrally focused. And when you give a light cured composite and you give in the light, the polymerization will be, the composite will shrink towards the light. This paper by Dr. Verselius is fantastic paper which gives a detailed insight into what happens actually when you're putting in a light, what happens when you give in a light at 45 degrees. So if you have a chance, go ahead and read this paper. I'll summarize this and tell you, the truth is the light does not matter. It is the shrinkage will always be towards the surface that is more bonded. Remember from the first slide, I told you that it's moving towards the enamel. It's not moving because, see here, I'm going to give a light on the top, right? Even my dentine has the same light as my enamel has, but what is happening? There's still shrinkage towards the enamel. That is why, because the composite, the movement of the shrinkage would be towards the most bonded surface. It is not towards the light. The surface which will bond faster, which will gain a lot of bond strength, there is where your composite will start moving. The dynamics is such that the light doesn't make a difference. So not why was this always said that when you move towards it, when you put in the light, you know, it moves towards the light. That is because when we put in the light, the deeper sections of a cavity do not get as much light strength, which is on the top of your tooth prep, right? So this area starts to develop a bonding much faster than the area at the bottom. And that is the reason why the light, the composite is shrinking towards the light or moving towards the light. But it's actually not towards the light, but it is actually towards this enamel surface, which is getting, because of the presence of the light, it's getting a bonding strength faster than at the base, because the amount of light intensity which is reaching at the base is slightly less than at the top. So if you see, this is an exact picture. If you focus on the center one, this is what is happening when you place in a light at 90 degrees, how this arrows will indicate the shrinkage of the composite, the movement and the dynamics of where the molecules are moving is this, you know, because there's less light on the bottom, the composite starts moving towards the more bonded. Also from the top, it starts moving towards the more bonded surface. Okay. So you can go ahead, read this paper, one of the best papers, and you know, it is just an eye opener for me. So now let's go into what is biomimetic dentistry. So in biomimetic dentistry, we do not talk about treating very small cavities. We do not talk about treating very small class 3s or very small class 4s. We talk more about treating, you know, teeth which look like this, you know. When a patient comes to you with teeth something like this, we talk about biomimetic approach. So what is biomimetic? New restorative approaches that do not aim to create a strongest restoration, but a restoration that is compatible with the mechanical and biological properties of underlying dental tissues. This is your biomimetic principle. So this was introduced by Dr. William Douglas in 1999. So dentistry that mimics the properties of natural teeth through adhesion and is based on an in-depth understanding of tooth structure, mechanics, and adhesion is what is your biomimetic dentistry. So what are my goals of biomimetic dentistry? to preserve the vitality of the pulp, to manage the polymerization and the residual stresses, to preserve all the remaining tooth structure and improve the biomechanics of the tooth. So when I talk about biomimetic dentistry, these are the teeth that you would want to treat with this kind of restorative dentistry. So not always you will have teeth which have very small, cavities. You're going to come across with in your clinical practice with a lot of teeth. The best option for you, when you look at this would be to go for a root canal, to go for a crown, to go for a root canal. This is what I was doing last 4 years. I would look at a tooth like this and, I would say this needs a root canal and this needs a crown. But today, from past 1 year, you won't believe there's very, very less root canals which I do for such kind of teeth unless they present with a proper symptom. 99% of the cases will come to you which are asymptomatic, and they come to you because they fractured a portion of your tooth, of their tooth. So they may look like this, but when you open them up, you'll find something like this inside. So what are the 6 lessons? So we actually, each of this lesson is itself a complete subject, and I'll try to give you an overview on what is going to be taught. So management of my carious lesion is the first thing which I would want to do. Then assessment and management of these structural compromises. I'll talk a little about this. Third step would be immediate dental sealing and resin coating. Fourth step would be my dentine replacement bio-base formation, but how? By managing the seal factor, controlling by decoupling and placing in the fibers. So when we talk about fibers, we talk about the reborn fibers, and why we do that, we'll talk about it. And then the last part is your enamel preparation and how you're going to replace your enamel, and then the occlusion adjustments. So to become a biomimetic master, you need to master in all of these 6 lessons. Each of the lessons has about 100 papers that you need to read and study to understand and gain knowledge on what is the dynamic of it. So management of your carious lesion, structural compromise, managing post-operative sensitivity is what is biomimetic restorative. But when you include the factor of aesthetic into it, you will find a group called as bioemulation. Dr. Pascal Magnet is one of the pioneers in this, and that group, along with managing rest of it, works on developing the aesthetics. When I talk about aesthetics, I just do not talk about A2, A3, A4, or managing C4, C2 colors. I'm talking about opalescence, translucency. It's amazing. You can just go ahead and look into their group and you will find the insight at which they are going to work. So a biomimetic approach is a bottom to top approach. What do we mean by that? We start at the base and we slowly build up the tooth rather than building up the tooth and then going in. So what we do is we start treating it from the bottom level. So to understand biomimetic dentistry, you need to master all of this, to understand the characteristics of adhesive systems. You need to understand the heterogeneity of your tooth structure, to understand the features of the tooth structure which is exposed after you've done your caries removal and you've done your abrasions. So today, of all of this, I'll be talking about the characteristics of the adhesive systems, which is very important as a basic to a biomimetic dentist. So establishing a bond requires time. We already understood. So before I begin with the adhesives, I would like you all to see this picture. This picture is from Dr. Junji Tagami's slide, where Dr. Junji Tagami is the chair and the head of the Tokyo Medical and Dental University of the Cardiology Department. And he was the student of Dr. Fusayama, who has done extensive work and research in the field of biomimetic dentistry and has left a legacy. So to go ahead, this is a section of a carious tooth. What they did was they took in a dye and they injected the dye, give it a positive pressure from the pulpal side. And this is what they noticed, see how much fluid is coming out from the tubules. When you have dentine is a living tissue, right? So this is what we are bonding to. We need to have it, and this is not, when we see this does not give us a clear picture of what we are bonding into it. But when we see this picture, we actually understand that, when we talk about dentine bonding, A dentine bonding, when you bond to a dentine is a living tissue, less mineralized tissue. It has a pulpal fluid coming in through there. And then you will have areas which is sound dentine, which will have carious dentine, which will have sclerotic dentine. So when we talk about dentine, it's just not the dentine. And then you will have dentine with perpendicular tubules, you'll have dentine with the parallel tubules. So when you go out and you start working, just don't see dentine as dentine. Try to locate the areas where there's a crack, where there's a sclerotic dentine, where there's a sound dentine, where there is a when you're on a pulpal gingival seat. So how are my tubules? My tubules are going to be parallel, and there'll be more fluid in those areas. When I'm going to be on pulpal floor, or when I'm going to be on a wall, it's almost perpendicular. So I'll have less fluid than I would have a gingival floor. So this is how I want you to look into your substrate, because understanding your substrate is very important before you start treating it. Look through your magnification, look into what you're trying to bond. So that is the key. Once you understand what you're bonding to and how you're going to bond to, is very easy. Why is it difficult to bond to deep dentine? Very high C factor, higher water content, large number of tubules, a large diameter of tubules, and that is why your hybrid layer takes a lot of time than your enamel to become mature. I'm not going to go into details about this, but I'm very quickly going to introduce it, because this is also a sound for your biomimetic. So Dr. Milchichi papers, if you go into them, he's given a concept called as the compression dome. So we all know about the biorim. So if we pass a line through the height of a convexity, just pass a line, the enamel all above the line would be what is your compression dome. And the enamel all below that line would be what you call as the biorim. So our focus should always be to preserve this biorim, not go for root canal, not go for crowns. When we get teeth, which I showed you before, with cracks, large amalgam restorations, if the tooth is vital, do not go and try to preserve as much biorim as you can. Just imagine a tooth like a tin can, okay? When you stand on top of your tin can, when it has a lid, no matter how much weight you have or weight you give it and you stand, it's not going to bend or flex. But now, just imagine you've removed the cap of your tin, okay? What is going to happen if you get the pressure or occlusal pressures and your lateral pressures? You're going to get a tooth which is going to get a tin which is going to get all crumpled up. Why? Why did this happen? Was, suppose there was this lid placed in there, would that happen? No. Imagine your tooth something like that. When you made an occlusal restoration on your tooth becomes like this. You've lost the significant portion of your enamel dome, your compression dome. That dome is one which was protecting your tooth from all the lateral and occlusal forces. Now, you went in, you made in a cavity preparations, whatever carious lesion was there, and you placed in a restoration. What happens is, now because the restoration is present, the dome is lost, which was protecting and directing our forces. The tooth will start flexing and bending much more than it was doing previously. And as it starts bending and flexing, the more of sensitivity, the more of bending and flexing, the tooth starts to develop a crack. Okay, so this is something, a small insight that I've given you to a compression dome concept. Easiest way to understand this. You need to really read more about this to get the complete idea about it. Okay, so let's go ahead. I'll show you a case. Okay, before I do any of my any of my work, even before giving anesthesia, it's mandatory that you do a cold testing. Okay, sometimes tooth may not be vital, and all your efforts will go into vain. So always make sure that such teeth which come with large amalgam restorations, cracks and fractured portions, although patient would have no problem, no pain, make sure you do the cold testing. You make certain of your vitality. So this was a case, young boy, 23 years old, presented to me. To be honest, he did not have any problem. He was absolutely fine with this tooth, no symptoms, nothing. Just because I could see a small portion of, disintegrating amalgam restoration over there, portion of fractured tooth, we decided to go ahead and remove this amalgam restoration. We did the cold testing, it was positive. We removed the amalgam restoration and this was the biomass at the base. How would we go about it? Start using caries indicator. Now, there are two schools, okay? There are two schools with one group which would say that you should use caries indicator, and another group of dentists who would say that, caries indicators are not good. Please do not use them. Now, what happened was when these caries indicators were introduced by Dr. Fusayama, there was no guideline on how you have to use the caries indicator. We were just given the caries indicator. We were told start removing whatever pink you see, or start removing whatever green you see when you use the other color. So what would happen is the dentist would keep removing it, keep removing, and they would result in the pulpal exposure. Without certain guidelines, you would always miss out on when to stop when you're using a caries indicator. So just do not use caries indicator without a complete knowledge about it. You can go ahead and read a paper by Dr. Pascal Magne and Dr. David Alleman on peripheral seal zone. They're given complete insight on how you have to do the caries removal. Okay, we'll talk about it a little more in some time. So go ahead. I used a caries indicator, started cleaning the tooth. I started from the periphery, I go from the periphery and then I go towards inside. Slowly and slowly, this takes time. Okay, biomimetic dentistry will take a lot of time. If you've scheduled a patient for an hour, be prepared that you're going to run late today. So start cleaning. I started cleaning it from inside. We saw that there's a lot of undermining over here. So we reduced the cusp cleaning. We started cleaning. Another cycle, once more, still a lot of tooth structure. Go ahead, clean it up once more. And this is where I stopped. You see that? From this, we could gain this. Now, if suppose I do not use a caries indicator, I would still go ahead and remove some more, or I would stop at a point which would not have been enough. Either it's too much or too less. I do not get a good, maybe with experience I'll get that, but when I use a caries indicator, I know for sure this is fine. I need to stop there. Maybe, a little pinkish here. But that's it. I know I can go ahead and bond to this kind of dentine. So what I do next, I apply my primer, okay? Remember, we do not bond your enamel and dentine together. So we first focus only on treating the dentine, and then is when we bond to enamel once we have already treated our dentine and have decoupled it with time. So I go ahead, I apply my prime, scrub it, apply my bond, scrub it, and then I apply a resin coat layer. So when do I start decoupling is when I apply this small 0.5 mm layer of a flowable composite after my priming bonding, and then I stop. I walk out of my chamber. The patient is under rubber dam. My assistant is there. We put in a timer for 5 minutes. We wait. Why do we wait now? Because I'm giving my dentine to bond, to become a little stronger, to become a little mature before applying any more or before building up any more of my tooth structure. Okay, so this is where we call as decoupling with time. So next step, what I do is I place in a patch of rebond. So we'll talk more about this. Right now, you can just see that we've done a placed in a patch of rebond. The reason why I've put in a rebond at the bottom of my cavity is not for the strength. The reason why I've placed a rebond at the base of my cavity is keeping in mind the future. Suppose my enamel replacement was not good enough and the tooth is still having a plunger, opposing plunger cusp, and I go ahead and I place in my enamel and the tooth cusp still fractures. What will this rebond at my base do is it will protect my pulp. It will direct my fracture towards the outside of the enamel surface and prevent the pulp to get involved in that fracture line. So this is going to prevent the crack propagation. So the reason why we place a rebond at the base of the cavity is not for its strength, because of its ability to propagate the crack in a different direction than towards the center of your tooth, that is your pulp. And then I build up my, after I finish my 5 minutes, I placed in my rebond, I build up my dentine. Okay, at this point, I have still not started bonding to my enamel. So when I do finish this part, this is called as a biobase. After I've done my biobase, I do not have the pictures for a small part of it. That is, I did the DME at the same day. I finished off with the DME, my camera charge discharged, and then we did this DME, and this is where we stopped. I literally stopped at this point, no bonding to the enamel anymore, okay? And we send the patient off for 1 day. We recalled the patient, took the measurements, we saw wherever we wanted to do a little more of soundproofing and see whether there's overhang. But this was a very simple case where we had an almost flat structure. We made a digital impression for the patient. I asked the lab for a dye because I wanted to record that, and we got like literally this was like 0.8 mm, I think, only Emax only. Veneer lay, I would call it a veneer lay because it had a lot of buccal involvement in that, and we cemented it. And this is the post-operative image. So now this is the least important part. What is the most important part is at the bottom. Do you see how close this is? No periapical lesion. Patient doesn't have any problem, you know. He doesn't have periapical, he doesn't have pain. But definitely he has a lot of sensitivity because the tooth is exposed. This shadow, what you see in there, is something what we call as a rebond shadow. So more important than my enamel is what I have inside, you know. If my inside is strong, even if my outside breaks, I know at one point that maybe after 10 years, maybe after 12 years, I will still have a patient come back with this intact dentine inside, dentine replacement inside. Max to max, what is going to happen after 10 years or 12 years is 5 years that my enamel may get, my Emax may get fractured. So this is what is your biomimetic dentistry, okay? How am I going to save the tooth? Let's see another tooth. Patient came with a dislodged amalgam restoration, no pain, no problems. We did the cold testing, pulp was vital. Literally patient was just with us because, you know, she could feel an empty space in there, okay? So we went ahead. Remember I told you when we have an occlusal cavity, the cracks start forming in because more flexing and bending. Do you see this crack here? This crack is called, this crack is present and you see a cavity. We call that as an occlusal effect caries. Okay, there's something called as occlusal effect caries. This caries has formed because of an occlusal cavity which was restoration which was present. So what would happen was there was an amalgam restoration present there. It had a crack developed over time. There were small caries. This caries started penetrating inside, started increasing, creating a secondary caries, and suddenly a portion of the patient tooth broke off along with the restoration. So patient is presented with this part to me, but it was a class 1 amalgam restoration to start off with. So this enamel effect caries is what I actually started understanding and seeing from last 1 year. Believe me, I've done dentistry. I've been doing restorations from last 13 years. But to be honest, I never understood this caries, why it was there. Only after reading those papers by Dr. Milchichi, I understood what is exactly happening in the tooth. So go ahead, do a little reading. We'll give you an insight. But most of the learning is going to be self-learning when you're going to read these papers, okay? So let's go ahead. We clean and clean and clean. We use the caries indicator 1 time, 2 time, 3 time. I think in this case, I used over 6 times. And then Yeah, so I'll give you a little insight into caries management at this point. Once you apply the caries indicator, you always need to remember that 2 mm inside your dentino-enamel junction, 2 mm inside your dentino junction, you need to have a sound dentine. No matter you have a soft carious dentine inside there, your 2 mm from your peripheral seal zone, that is from your DEJ, dentino-enamel junction or the dentino-enamel complex that we call, you need to have a sound dentine of 2 mm. You know, no pink. That is your no pink at all. Now here you have a dark pink, you have a light pink. That is of later concern, but 2 mm within your dentino-enamel junction has to be completely sound dentine. So now this is the dentine which is going to give the strength to your restoration. This is the dentine which is going to prevent your post-operative pain. This is the dentine which is going to last long even if your enamel has failed. Okay, so when we go into, this is a slide from Dr. Junji Takami, he talks about carious lesion. There's a transparent dentine, there's a softening zone, and there's a reparative dentine. So where do you stop? Your discoloration would be till here. Okay, this is the point. Whenever you see transparent dentine coming up, you know, very small, you would know you've overdone it. Okay, so where do you stop is, I'll give you an insight into the colors in a moment. Okay, so most of us rely on these spoon excavators and the pair of probes. This can be very subjective. Something hard to me may not be hard to you. And another problem is, as you start going deeper and deeper, your dentine becomes softer and softer. Okay, so you do not know whether it's a soft dentine or whether it is a dentine which is soft because of the bacterial invasion. So to be honest, I've completely given away with both these tactile treatments in my clinic, and what we trust into is the caries detector, and it's given me fabulous results. And you know, I have seen so many times, you know, initially I would not trust being a clinician. I would always test everything before using it on my patients. I would not trust it. So what I would do was, I would go ahead, prepare without using a caries indicator. This happened for at least 1 month. We did this for 1 month. We would prepare as much we would stop at, okay? And then I would apply my caries indicator to see and test, you know, have I done properly or not? Every time I would have some carious lesion which I would have left in, especially in these areas, you know, in these areas, not in this area, you know, on the walls. Because when we use the probe, we do not actually go and check the tactile sensations on these walls. Okay, so that is how I started absolutely applying it to my practice, and it has been a good indicator for me. So when we talk about peripheral seal zone, your dentino-enamel junction, from your dentino-enamel junction, I want you to be 2 mm, 2.5 mm free of the carious lesion, absolutely white, no pink in those areas. Okay, now what happens in the center is, where do you stop? You know, now people would go ahead, keep removing. If this doesn't happen, if you keep doing that, you're going to go and enter into a pulpal exposure. So at some point you have to stop, right? So now quickly we'll look into the measurement, we will stop. Another thing, we've always been taught to use this SS kind of burr, okay? Now, this SS burr is fine if you're using an etching based dentine bonding agent, okay? If you're using an etch based dentine bonding agent. But if you're using something called as self-etching bonding agents, I would not recommend you to use this, because this will create a smear layer which is very thick, okay? And your self-etching systems will not be able to penetrate into such a thick smear layer. Use something which is like a diamond point, which will create a thinner smear layer. Okay, so my choice is, because I use a self-etching dentine bonding agents, my choice is my point. Okay, go ahead. This is the exact measurement when you have to stop. Okay, from your pit, that is your groove, 5 mm is your measurement from top to the bottom, and from your proximal area to your judgment, 3 mm would be fine, but as you go deeper and deeper and deeper, you need to clinically understand that this size will become less. And if you have patients who have very small clinical cryouts, this 5 can also become 4. Patients who've got attrition, this 5 can become even 3. Okay, so but on an average, if you take a sound tooth structure, 3 mm from the top, from occlusally, 5 mm from the occlusally, and 3 mm from your proximal is your stop point. Any more you go beyond that, you're going to result in a pulpal exposure. So even if your cavity is having pink, bright pink, you know, it's showing carious lesion, stop at that point. When you bond to it, your reparative work of the tooth will take care of that soft carious lesion. Okay, so from the case behind, we went ahead, and this was more of a caries in the proximal area. There's caries in the distal of the mesial of the 7. So we did another layer of it, and this is where we ended with a caries removal. So that was my caries endpoint removal. After I think 6-7 times of using the caries indicator, carefully removing it under magnification, that is the point where I stopped. Okay. Now, this is a paper by Momoy, okay, excellent paper. So everybody would have a problem on when to stop. How pink is a pink to stop, okay? So a group of dentists from the Japan, all the academicians sat down together with the clinicians. They formed a paper, and this bar below is a guideline on what to remove and what to not remove. Go ahead, read this paper. I'll forward some of these papers to Ashish sir, and he'll provide to all of you. But clinically, if you want to see, just remember this, okay? You do not remove this light pink, okay? What you remove is this pink. Let's go ahead. After that, I did the air abrasion. Air abrasion is very essential of your biomimetic dentistry. I did in the air abrasion, then primed on my dentine. When I've done with the priming, it should look shiny. Then I put in my bond, then I put in my resin coat layer. Remember, after putting in my bond, curing my bond, a very thin layer of 0.5 mm flowable composite I'm going to place, not more than 0.5 mm, and then I walk out of my chamber. I give in 5 minutes to this patient. Let this bond become mature. So this is what is called as decoupling with time. After my 5 minutes, I come back, I place in the rebond, I build up my bio base. That is the remaining part of my dentine. I've replaced it with a composite material. I packed in the temporary. I was already 1.5 hours running late. I packed in the temporary. I sent the patient off. Now, this also has a very importance, because to gain 99% of the bond strength, you need 24-hour time. You need to give in time to dentine for 24 hours. Here, I was trying to do a direct restoration. If I place in a direct restoration, I might not get the full bond strength. So next day, I recalled the patient. I opened up these grooves, finished off my restoration on the 7. Then I did my BioClear restoration technique and I restored etch. So whenever you're going to bond into enamel, always remember you cannot use a self-etching system. You need to etch your enamel, okay? Even if you're having single bottle systems or multi-mode systems, enamel needs etching. Those who say that just apply the bonding agent on enamel and it will work, it doesn't work. You need to etch the enamel for the maximum bond strength, even if you're using the newer bottle systems. Go ahead, finish, polish, and this was my finished restoration after the occlusion check. Okay, and if you see this radiograph, after doing the treatment, and I was shocked, you know, I was shocked. But again, this patient literally has 1 year follow-up with me next 1 month. So no problems, absolutely fine. Good proximal contact, surviving. So, ma'am, at this point, I would just like to know how much time do I have? Because I understand that we are running very, very late today.
Yeah, another 15 minutes you can take, no problem.
Okay, so I'll go ahead and finish with the bonding systems, okay? That should be over in 15 minutes and maybe show you one more case, okay? So let's go and understand and simplify the bonding system, because you'll understand the essence of biomimetic dentistry is not on how beautiful you make your restoration. It is on how good bond strength do you gain, you know, advanced bonding techniques. So let's understand into bonding agents. I'm going to go through the generations very quickly. I'm not going to talk about first 3 generations. It's obsolete. Nobody talks about it anymore. Let's start with the simplifying it. So whenever a medical representative, MR, from any company, 3M, Bisco, Curare, Dentsply, Ivoclar is going to, GC is going to come to you. They're going to come, when you start your clinic, you buy our bond, it's the best. Buy this bond, it's the best. After 6 months, they'll come up with another bond system and they'll tell you, they have added something new in this bond, try this one, the old one had these problems, try this new one. This is going to give you the best bond strength. I've had all of those over many years. I never understood until and unless I actually read all of the Dr. Van Merbeek paper. Go ahead and read all of the Dr. Van Merbeek papers. He's done phenomenal. His team at Belgium is doing phenomenal job. And trust me, you'll get a very good insight. Now to simplify, imagine bonding systems as 3 components, okay? Etching, priming, and bonding. So your 4th generation had a separate etch, it had a separate prime, and it had a separate bond. So what is an etch? Etch is something like an acid that you're going to, it can be this 37% phosphoric acid, it can be malic acid, it can be citric acid, or it can be acids like nitric acid, any acid, okay, which you're going to use to remove or demineralize your enamel or your dentine is your etch. So right now, today, we are not going to talk about enamel. We're just going to concentrate on dentine because in such big lesions, definitely we're going to take the enamel as an importance for a bonding of the enamel replacement. But because these lesions have a lot of dentine, we cannot just say that we're going to rely on the enamel. We need to make sure that our dentine is very much stronger. Okay, so etching is your substance that is going to remove or demineralize your dentine to a certain extent. So it's also going to work on your smear layer. It is also going to work on the first layer of the dentine that may remove and expose your collagen network. So everybody's done PJR. You all have a fair idea about it. So I'm not going to go into basics and go and talk a little more higher. So what is prime? Okay, prime, because dentine is a living tissue, it has a water. If you start applying something which is very hydrophobic, it's not going to work. So prime is something which are methacrylates only, it's a bonding agent only, but it is having hydrophilic ends, okay? These hydrophilic ends allow you to bond to a surface which is wet, okay? Now what is bond? Bond has something which is hydrophobic, which is actually going to form your bonding to the composite, because composite is again a hydrophobic material. So hydrophobic, you need something to bond. So prime and bond are going to bond together with CC bonds, and your bond, if you apply directly without priming, may not flow inside the tubules as well as when you do with the prime. So what happened in the 4th generation? They had etch separately, they had prime separately, they had bond separately. Okay, what happened with the 5th generation? They said, okay, we'll have etch separately, but we will. Okay, can I go ahead? Sorry, can I go ahead with the lecture?
Yes, Dr. Disha.
Okay, so then they said, it's taking too much time, separately apply the etch, separately apply the prime, separately apply the bond. It's taking too much time. We're going to put etching as one step and we are going to put prime and bond in one bottle. So that was your 5th generation, okay? Then came in the 6th generation. 6th generation said, I'm not going to etch separately. I'm going to etch and prime in one bottle and I'm going to bond one separately.
Yes, Disha, you can go ahead. You can go ahead. No, you can go ahead. You can go ahead.
Yes.
Okay, so the so the 4th generation said that I'll do etch separately, prime separately, bond separately. 5th generation said I'll etch separately, but I'll prime and bond together. Now 6th generation said I don't want to etch separately. I'm going to etch and prime together and bond separately. Now 6th generation also generated a system which would be 2 bottles mixed together, but etch, prime and bond together. Now, the newer generations, what did they said? You don't need to do anything. I'll give you one bottle, which will also do etching, which will also do priming, which will also do your bonding. Something like a salad, where you mix in everything. You mix in water also, you mix in oil also, you mix in your fruits also, okay? So, 7th generation is good for your enamel. They do not work for the dentine, okay? Please remember this. All those companies telling you, go back, study a little more on this. Your 7 generations do not work for your dentine. They work fine for your enamel, but they do not work for your dentine. So I'll repeat this again. 4 generations set, I'll etch separately, prime separately, bond separately. 5th generation set, I'll etch once, but I'll prime and bond together. So that was my 5th generation. 6th generation set, I'll etch and prime together and bond separately. Okay. And then 6th generation also had one where they would etch and prime 2 bottles, but mix together into 1 bottle. And then the newer generation said, I won't do any of it. I'll use 1 bottle. I'll be fast, I'll be quick, and I'll just use 1 bottle. So I'll etch, prime, and bond together. And it was a big failure. So the 7th generation, because they were starting to realize that they're also failing on this, they said, no, you can apply etch and use the same bond. Okay. So coming to the 4th generation. Okay. What did 4th generation? Prime separate, sorry, etch separate, prime separate, and bond separate. So now, when I talk about dentine bonding agents, Dr. Van Merbeek has approved, his team has approved only 2 bonding agents, which are your gold standard. So when I talk about gold standard, it means that they've passed the time and they've been tested over years and years, minimum of 10 to 15 years, and they have still proved to give the best bond strength. Okay, so in the 4th generation, we have 1 bond which is called as OptiBond FL, which is your gold standard. So when I talk about using bonds, there are only 2 bonds which meet my criteria or the criteria to be actually used in your clinic. Okay, so there is 2 bonds, which is your 4th generation OptiBond FL and your 6th generation Clearfill SE bond. Okay, these are the only 2 bonds which are actually giving you the highest bond strength, and they've been tested time and time, thousands of articles comparing them with other bonding agents. So what do we do when we do a 4th generation? We go ahead, prepare our cavity. So this is some of the smear layer present. I go ahead, do the etching. All of the smeared layer is lost, and my collagen matrix is exposed because some portion of my minerals from the dentine is lost. Okay. Now, once that collagen network is exposed, I go ahead, apply my prime, then apply my bond, and then on top of, I wait for some time, and then I go ahead and apply my composite. Now, when I say OptiBond FL, okay, OptiBond FL has a bond which has filler in it. FL, it stands for filler in it. Okay, so we edged it, then we applied the prime, which was hydrophilic monomers, and then we applied a bond. So in this case, you remember in all my cases, I was applying a thin layer of resin coating. When you use an OptiBond FL, you do not need to do a resin coating. Okay, in all my cases, I use Clearfill SE, which is your 6th generation. But you do not need to apply a resin coating in your OptiBond FL, because your OptiBond FL has already a filler in it. That is the only bond which has filler in it. Okay, so because it has a filler, it has the ability to resist all the hydrostatic pressure from the dentinal tubules. It is having that kind of strength that will reduce the forces from your dentinal tubules. Okay. So whenever you're going to use an OptiBond FL, you do not need to do a thin layer of 0.5 mm. So after you've applied your bond, cured it, straight away wait for 5 minutes, and then you can start layering your composite for the dentine replacement. Okay, so that is your OptiBond FL. Now, 5th generation was, they said, most widely used composite bonding agent, which I think all of us in India have used it. But the problems, it is a good system, okay, but it is very, very technique sensitive. What I mean to say is, remember when we had the MR come in, we told them we're still having patients with post-operative sensitivity. They said, scrub it, scrub your bond. Okay, we started scrubbing it. Then they came and said, air dry your bond. Okay, then we started air drying it. Then they came and said, after you have applied the edge, start using some filter paper or cotton. Don't air dry it properly, completely. The collagen matrix will completely collapse. So this gave good results, but the problem with this was the consistency. It was very technique sensitive. For what we did the etching, okay, collagen matrix would get exposed. Now the moisture content was very important after this collagen matrix got exposed. Suppose I remove a lot of water, my collagen will get collapsed. Okay, suppose I do not remove water, there'll be water-free phenomenon problems, there'll be a lot of debonding because of the water present inside my hybrid layer. Now, so if the perfect somehow nobody was able to gain a perfect kind of consistency with this. What we did, we placed in our bond. What happened was, you see these areas, complete penetration of the matrix did not take place. Okay, so we got some areas where a monomer would flow into the collagen matrix, but some of these collagen matrix would still stay devoid of the bonding agent. So because they would stay devoid, over the time they would undergo hydrolytic degradation, and the MMPs would get activated in those hybridoid zones which were empty and devoid, and we would result in failure after a few years. Okay, so this was very technique sensitive, and when I say that the 5th generation was gold standard, no, none of these studies, although most of these studies are in vitro studies, it's not possible to standardize for clinical trials in such cases. Most of the in vitro studies says that this did not work very well. Now coming to what I use in my practice, I would prefer to use OptiBond FL in many cases, but in India we do not have OptiBond FL present. So what I use is something called as Clearfill Bond, SE bond. Okay, Clearfill Bond is a 6th generation. Remember, we spoke about 6th generation where we do not have the etching step. We have one bottle which is my prime, and we have one bottle which is my bond. Okay. 1 second, please. Now this prime is a self-etching prime. It has an etch in it which is going to demineralize my dentine, penetrate into the smear layer, and create a good bond strength. So the bottle, the first bottle, which is this one, the primer bottle, it also has, this was one of the first bonding agents. Curare was one of the first company which actually also created just give me 1 minute. I have some problem. Presentation. Can everybody hear me?
Yes, ma'am. Yes, ma'am.
Okay, I have some annotation or something coming up. Okay, anyway, I'll just go ahead because we have got less time. So the prime is something which is also has a self etch in it. So it's going to cause a little bit of demineralization. It's going to penetrate into my smear layer, but it is also going to keep a lot of calcium from my smear layer present in that. And very quickly, we'll talk about in few slides why we want that calcium to be present when we bond to the dentine. Okay, and the second is the bond, which is your monomers. Okay, so we have the smear layer. We did air abrasion. It's very important that with self-etching systems that we do an air abrasion, because the smear layer, if it is very thick, if my smear layer is very thick, it is not going to, my self-etch primer will not be able to penetrate to it. So when we do an air abrasion with alumina is going to remove a part of my smear layer. Also, it is going to impact some of the partially mineralized calcium into the tubules. Okay, when they do that, your hydrostatic pressure, the pulpal fluid will reduce. You will have less sensitivity. So there's a lot of importance to it when we use the alumina. And then we are going to prime. 20 seconds, we're going to scrub the prime because we really want the prime to go into the tubules, okay, or the demineralized, exposed, little bit of exposed collagen. The prime, scrub it. Once it looks a little shiny, go ahead, apply your bond. Do not air dry your bond. If you air dry your bond will have oxygen inhibition layer in it, okay? So what you do is, with your applicator tip, just wick away all the excess. Do not apply too much of bond, you know, just wick away whatever excess is there and cure it. Once you've cured it, apply a thin layer of resin coat, because the hybrid layer which is formed by the SE layer, SE bond is very thin. It's around only 2 micron, 2 to 5 micron. Okay, so I'm going to, and it's not a filled bond. So I'm going to give a very, very 0.05 layer of my flowable composite, not thicker than 0.5 mm, and then start to wait. Then is when my decoupling with time this starts. I wait for 5 minutes and then start applying composite. Okay, so that is most about it. We've already spoken about air abrasion. Why we want to do it with alumina is because we want to create micro. The reason sodium bicarbonate does not have that ability to create the micro abrasions. Okay, so always use an alumina. The importance of Whitlock. Okay, this is something which I'll discuss because it's very difficult to understand also. Remember, I told you that SE Bond was one of the first companies to put in the MDP. Now, MDP is something which is going to chemically, we've always learned, right? It's a micromechanical retention. With the addition of MDP, we could gain a lot of chemical bond. Okay, what I mean by chemical bonding is the reality of what Dr. Fusayama had foresight that, you know, I'm able to chemically bond my composite happened with the MDP. Now, for the MDP to function, you need these calcium. Okay, that calcium which is present in the in your smear layer, the calcium which is present on the exposed dentine surface, you need this. Then only your MDP will bond to it. Okay, it will self-arrange in a nano layering layer and will function. Okay, this is something, it's little difficult to understand. Two monomer bonds will bond to the calcium like region in there, and then that is how your super dentine layer with the MDP is formed. Okay, so 3 modes of interaction will actually result in a chemical bond. You know, phosphoric acid esters with hydroxyapatite calcium, that is your Whitlock from your partially demineralized calcium from your smear layer, and the calcium from your dentine. Together will help the MDP to create a very strong covalent bond. So when I say that this ionic and covalent bond, does MDP increase my bond strength? No, it does not increase. Addition of MDP does not increase my bond strength. But what it does is it increases my bond stability. Something which is going to die in 10 days will take 2 years to die. Okay, that is what is the role of the MDP. Coming to the 7th generation, we all are using this. Almost everybody has this in the clinic. This is good for enamel, but when we talk about dentine, you see there's a lot of debonding. If you see the SEM image, there is a lot of debonding in this. Okay. So good to use them for enamel, but it doesn't work for dentine. For dentine, you have only 2 bond systems, your Clearfill SE bond and your OptiBond FL. So since OptiBond FL is not easily available in India, my to go is your SE bond. Okay. So now I'll quickly wrap up with this. Dr. Van Merbeek, very difficult to remember the generations. So he gave in a very simple classification: H&RINS, self-etch, and multi-mode. Okay. So H&RINS, 3-step, 2-step, 4th generation, 5th generation. This is your 6th generation, and this is your 7th generation. Okay. So hierarchy of bondability is something which I told you in the beginning, that different parts of the tooth will form hybrid layer at different time. So this is your beveled enamel, will take 5 minutes, your superficial dentine 30 minutes. This kind of bond strength, you know, we are looking at something like 45 megapascal to generate the bond strength, you know, which is more than your beveled enamel bond strength. So coming back to my first question, does composite bond stronger to enamel or to dentine? When I show the slide, it is only my dentine. Remember, 2 mm within the peripheral seal zone, that dentine is what is going to give the bond strength. That is your 45 megapascal. It will prevent sensitivity. It will prevent future fracture of your restorations. Okay. So this is an insight. My friend, Dr. Ashley Chong, picture from her. Beautiful picture trying to tell you what is actually happening and what you really need to see when you do it. So another term what we call is biobase. Biobase is a complete term we use for a dentine replacement. So this is at this stage is what I would call my biobase done. Okay. So my air abrasion, priming, bonding, resin coating, and deep margin elevation and dentine replacement together forms my biobase. Okay, ma'am had asked me to talk a little about Rebond. It will just take 5 minutes and I'll just very quickly go through this. Why I want to use a Rebond. Rebond is basically a polyethylene fiber. Okay, something like this. It comes in many thicknesses and many sizes, 2 mm, 3 mm. But the reason why I want to use Rebond, I've already shared with you. I do a restoration. I foresee that in future it may fracture, but I want to preserve my pulp. So that is my Rebond sitting there preserving my pulp. Now I can also use this Rebond in endodontic treatment. Go ahead, read a lot of papers by Dr. Sema Belli. She's a student of Dr. Aino Shoki, who's done a lot of work. Again, student of Dr. Fusayama. She's written phenomenal papers on Rebond. It has a lino weave, the modulus of elasticity is very strong. You try to cut a fiber post and you try to cut a Rebond with burr, and you will understand why I have almost eliminated fiber post from my practice. You can take a picture of this if you want. This is an insight into what you have to do. This is your IDS. IDS, I mean, is your prime air abrasion, prime bond. Then a thin film of Rebond in my Everex posterior or Everex flow. Then I do my DME with the APX resin or whatever resin you're using in your clinic, and then build up your dentine. So that is your bio base. Okay. Okay, very quickly, I'll go through one case. Very nice. Just give me 1 second. I'll be there in 1 minute. Sorry for the interruption. I'll very quickly go through this. This is a case. Trust me, this was a case which actually changed the way I looked into things. A young patient, only 23 years old again. She came up with a failing restoration, composite restoration. I did not expect something like this in her mouth. Okay, when we removed the restoration, cracks and cracks everywhere. You know, this crack. Actually, she had already lost her contralateral molar because of this. Some dentist had done her root canal, and after a few days, she fractured her crown altogether. So cracks and cracks everywhere. This is a little deeper inside, where you know, we structurally determine, you know, this is a strong cusp, this is a weak cusp, whether I have a crack in the dentine or not. So if I see a risk assessment, first is whether I see there's a crack or not. Second thing I see is my isthmus bigger than 2 mm or not. Is my cusp thickness less than 3 mm? And the fourth is where I see whether the box is deep or not. So is there a crack present? Is the cavity very wide? Is it more than 2 mm? Is the cusp thickness less than 3 mm? Is my proximal box more than 4 mm? If any of this is present, the tooth is a structurally compromised tooth. You need to give an inlay or an onlay onto it. Okay, so this is something a little advanced which you learn at a later stage. To reduce the sensitivity, all in my peripheral seal zone, I removed the crack. You know, we go in and do a crack dissection. So at 4 points actually, and even at this point, we did the crack dissection. Okay, and then we did the biobase, rebond and the biobase, build up the tooth structure, and did the final restoration. So not a lot of anatomy here because the tooth is under too much of flexing. Very mild, simple anatomy was given to this patient, did not given even the stains because we were just trying to save this tooth. So if you see this, this is the post-operative radiograph for the patient. Okay, this is something which we can skip. Rebond, this is a case which is actually very similar, which shows a, you know, here I have almost exposed to the transparent dentine, did the rebond RC layer and placed in a rebond, sent the patient off, recall next day, and did a very nice BioClear restoration for the patient. And this is the image of the IOPM. Very quickly, once the pulp is lost, rebond, whatever cases I showed you was for restorative dentistry, but you can also use it for your endodontic treatment. Okay, in this case, I'm not going to use my rebond for preserving my pulp. My pulp is already lost. Here I'm going to use my rebond to protect the remaining tooth structure. So how do I use a rebond to create a post? Okay, put a crisscross like that. Put a put the prime inside your canal, put the bond, put your dual cure resin cement, and once you place your dual cure resin cement, form this crisscross and insert it into your resin cement. Okay, something like this. This was a patient who came to me. This was my failure. I had placed a metal post and he came back with a fractured metal post. And that point, he was having a full mouth rehab, and it did not seem like I can remove all the bridges and redo the whole work. So I created a rebond post for him, and it gave him an anterior 360 BioClear crown. Trust me, this was during the lockdown period, so I do not have too much documentation on this. But this was the result which I could gain and give him immediately a tooth back using the rebond technique and the BioClear technique. So I utilized the internal ferrule, no removal of tooth structure, and the external ferrule which was present to me, and engaged it much deeper with the 360 BioClear vitrile. So this is another case where I've used both the biomimetic and the BioClear technique to give a good result to the patient. So very quickly with my microscope, I just clicked one picture. So again, in this if you see, here I'm not using the rebond for my pulp, right? I'm using it to create a structural integrity. Okay, instead of using a post, a fiber post, I'm placing a rebond 360-degree collar all around. Okay, try to adapt this rebond on the existing tooth structure very well. Try to gain a lot of tooth strength, adapt it very well to that. And this is the radiographic presentation out of this case. Next case, yeah. Another case where instead of putting a fiber post, I created a rebond post. Okay, and I'll very quickly tell you why I'm aiming towards using a rebond as a post. Okay, another case where after the endodontic treatment and sealing it, we removed more of the carious lesion. You see how caries indicator helped me even if I feel that, you know, I've removed enough tooth structure and it's sound, but, you know, it gives me a clear indication at so many places that, you know, it's not enough. And then I use a 360-degree. I created a wall, a peripheral wall, and 360-degree I gave in a wallpapering technique. Okay. And that is how this was the radiograph of the same tooth which I showed before. Do you see at this point you may feel, you know, I would feel if I was not using caries indicator, I would stop at that point and start doing maybe a fiber and start replacing my Everex posterior or bulk fill composite, whatever I would use. But now see, you see from this visual to this how much caries is still present. What we feel that we've removed, especially on the walls, I told you, right? We miss out all on the walls. And this is what I received after, I think, 2 or 3 times of staining. Good clean walls, and then I did a wallpapering for the patient. And we did not do a complete crown for this patient. We just gave an onlay for this patient. So that is all. Okay, I'll just tell you the reason why we are using rebond post is, now when we are going to place a rebond is an inert material. Okay, it does not compete with my composite to move towards it. When I place something like a silinated fiber post, and there are 2 walls, right? The composite present, the dual cure composite present is competing to bond both to the silinated post. Also, it is competing to bond towards my dentine wall. Okay, so what is happening? My bond, the composite shrinkage is moving towards the silinated post because it will create a more bond strength. So essentially, when I placed a fiber post, which was more silinated, the bond strength from the dentine is losing because the composite starts moving towards my post. Whereas when I place in a rebond is an inert material. Okay, it does not, it is just a fiber which will mechanically lock all the composite. Okay, and once it sets, it becomes so hard. The modulus of elasticity is very good. Actually, it allows a little flex also, but it stays very hard also at the same point. So my rebond does not compete with my dentine wall. So the shrinkage when I place in a rebond post does not cause it to move towards the rebond, but towards the dentine wall. So my bonding of the dual cure cement is going to be more towards the dentine bond than towards the post. This is the reason why I have absolutely eliminated fiber post from my practice and have completely switched over to the resin bond, towards the rebond post. So with this, I would say biomimetic dentistry, 6 layers, 7 times. Your Clearfill RE, you have to keep applying. So it takes a lot of time, okay? And initially, trust me, I took a lot of time. A case which was scheduled, which I would initially complete in 1 hour, it's like halfway through, only 2.5 hours is gone. Because you see carefully, you do the work very slowly, layer by layer, and then you build it from the top and from the bottom to the top. It takes time. So, you really need to believe in yourself and you need to believe into your dentistry to do this kind of work. So, to quickly summarize, air particle abrasion, air dry it, prime for 30 seconds. This is for Clearfill SE, okay? Bond it, do not air dry because you're going to incorporate oxygen inhibition layer. Cure it for 20 seconds, apply a resin coat, 4.5 seconds, and wait for 5 minutes. Wait for 5 minutes, okay? And then start creating your composite layers, okay? This is your 6 lessons which you have to master to become a biomimetic dentist, okay? Today we covered a little on caries management and a little on immediate dentine sealing. So with this, thank you so much for all your time. I know we are all running very late and very late for lunch. Sorry for the delay. I hope you've got some insights into biomimetic dentistry. Thank you so much.
Thank you, ma'am. Thank you so much. Ma'am, can you please stop sharing your slide?
Yeah, I'll just do that. Just give me 1 minute. Yeah.
Yeah.
Okay.
Yeah. Yes, ma'am. It's done. Yes, ma'am. Thank you so much, ma'am, for sharing your
welcome.
knowledge on this particular topic, both theoretically as well as the practical aspect of it. Thank you so much. And ma'am, this is, we would like to give a certificate to you. Yeah. Can you see? Is it visible?
Thank you so much. Thank you so much for this. It's very kind of you.
Thank you. Thank you so much. And I'm very sorry I was unable to reconnect for Dr. Abdul's certificate. So this is the certificate of Dr. Abdul Rahman. So,
We can mail it to him. I think that should do.
Yes. We plan to mail it to him.
Yes.
So, ma'am, if you have any questions, we can take that.
Yeah.
No?
Yeah, you have some questions. So the first one is, what is the kind of temporary you use? I mean, after you do your biobase, you said you're going to re-restore the next day, right? So what is the
Yes,
in-between
sometimes I
temporary?
do that.
Yeah. So
So
what is the
there are 2 types of temporary that you use. So if my dental technician is present and is in the clinic that day, so he forms me a bisacrylic temporary, which we make it with ProTemp or with a cold cure composite sometimes. Or sometimes if I'm running really late and do not have that patience, there's something called as a Spident temporary material, okay, which is blue in color. It's by a company called as Spident, okay, Spident. So it's a blue color resin material which does not bond to the tooth, but it sets with the light. So I just put that, and then just cure it. So because it's blue in color, I'm easily able to remove it next time.
Is it something what the orthodontist use? Is it something like that?
No, not the right bite. No. That is a proper composite that's going to bond to the tooth structure. This doesn't bond. It just stays a little strong and it just sits there. It maintains the shape. So
Okay,
there's no movement in the tooth as such.
Okay, for removal of caries after the caries dye detector, you suggested some kind of burr, right? Can you elaborate on that, please? It was not very clear.
So I just recommend using a diamond point instead of an SS burr, because I'm using Clearfill SE in my practice as a gold standard bonding agent. So now Clearfill SE requires a very thin smearing. Okay, or if you're doing an air abrasion, it doesn't matter so much. But in case you're not doing an air abrasion, you would want to use a Clearfill SE because it will create very thin smear layer. If you start using SS bar, it will create a very thick smear layer, and your cell edge will not be able to penetrate into that.
Okay, one more question. Would you use EverX Flow with the these fibers inside it?
Yes,
EverX
yes,
Flow
it's an
Yeah.
excellent material, but there is a rule to using EverX Flow. You can follow Dr. Philip Coleman. He's presenting a lot of work on that. He's one of the developers of EverX Flow. So in EverX Flow, the modulus of elasticity is going to be 9 gigapascals. Okay, so you can use EverX Flow, but you cannot use it to do a complete dentine replacement. You can just use it right after your resin coating layer to insert your rebond if you want. And another rule, because it's a flowable, it's going to shrink more. Okay, so you cannot use it in thickness more than 1 mm. 1 to 1.5 mm is the maximum thickness which we should use with the EverX Flow.
Okay, one more question. So basically, all the cases what you have shown are deep decays, right? Whatever you showed. Now,
Yes,
traditionally
yes.
we used to use resin modified glass ionomer. Is that totally eliminated with the biomimetic approach using GIC?
Totally eliminated. It does not have bond strength. There's so many papers which will tell you that the bond strength with resin modified GIC is not good. GIC is actually totally eliminated. Even the pulp liners is totally eliminated. So what actually technically what I use is something I'll just show you, which is not available in India. But I can show you. Is my video visible?
Yeah.
So I use something called as Clearfill SE Protect. If you see the system, this has something called as MDPB in it. Okay, MDPB. So now that MDPB is also antibactericidal. Okay, that's an antibacterial. So they say that if you use Protect in a deep caries lesion, you do not need to give any pulp lining agent. Your body is going to do that work because we are
Okay.
still in the vital tissue.
What about in terms of as vital pulp that we're using biodentine and MT and all that?
So
That
the
is
vital, so if there is a pulp exposure, then it is okay to use a biodentine and an MTA. But then if there is a pulp exposure, it does not stay into realms of restorative dentistry. It moves towards the endodontic. So
no.
when we
What I'm
talk
asking
about
is,
vital,
sorry, what I'm asking is, suppose there's indirect pulp capping, suppose it's very deep. So is it okay to use biodentine and then do all this stuff on top of it?
yeah, it's okay. We can use MT and we can use biodentine, but just put it. There has to be a rule. Cannot be more than 1 mm of exposure.
Yeah, if there is exposure. Okay. Ma'am, any questions?
Yeah, no, I don't have any questions because Dr. Disha was so, perfect in her presentation. She did a wonderful job and she's given us a new concept called decoupling. I think this is something new to most of us because we never thought of bonding dentine separately, bonding enamel separately. Now that is something that she's given a new concept to us. Now let us sort of start following her concept and see how best it works. I'm sure it will work wonders for our restorative dentistry. Thank you, Dr. Disha.
Yeah, Dr. Disha, I think that was one of the fantastic presentations I personally have seen. As far as any international, your concepts are so clear. And I think the PGs have got a lot to learn, not only the PGs, I think even the faculty.
Even the clinicians, yes.
Yes. So
Ishi,
thank you for that. And it shows your passion towards your subject. We're very happy having you here. So with that, I think we end our session. And we have the next talk coming on instrument retrieval. And these are two fantastic young clinicians who are actually going to show you how to use different techniques for removing the instruments. And I don't think so as PG students, you should miss this because all these lectures, we're trying to keep it more clinically oriented and less amount of theory. So this is coming up on 21st, Friday. So same time, 11 and 12 o'clock. So I think please do make time and see how these guys do. One of them has his own patented technology, and I think you should take the full advantage of this in learning how to do this. And I think that's about it. So signing off. Thank you very much for your participation.
Yeah. Thank you, Dr. Disha. That was a wonderful
Oh,
presentation.
sorry, ma'am, I got disconnected.
Yeah, thank you. It was very nice. It was very nice and very clinically oriented, and your concepts are very clear. And it was really, I'm sure it is going to be very useful to all our postgraduates and clinicians as well. Thank you.
Thank you so much.
Thank
And
you.
Thank you.
yeah, I would like to end this session by thanking all the participants, both faculty and postgraduates who have assembled here. I'm sure you would have benefited immensely from both the presentations because the topics are something totally new, because BioClear matrices we've all heard of, we've all read in articles, maybe seen a few videos, but at close quarters we've not had an exposure to it. And from Dr. Disha, so many new concepts that she has learned over the years. I really appreciate her passion and her dedication to the field of restorative dentistry. Hats off. I think all the PGs have to take a cue from her passion. From where you leave, when you leave your college, this is where you have to head. And I think she will be a nice mentor to guide you all. Thank you, Dr. Disha. Thank you one and all for your active participation. We'll meet again. We'll sign off now. We'll meet again on Friday, same time. Thank you.
Thank you to all my PGs also. Bye. Bye, Disha. Thank you.
Bye, sir. You're welcome, sir.